The following podcast is part of a certified educational activity titled Harnessing the Power of ADCs in Gynecologic Cancers, Expert Insights for Practice Integration. Access the entire activity and complete the post-test at peerview.com/UAD860. Downloadable slides are also available.
Hello, I'm Dr. Kathleen Moore, a professor of gynecologic oncology and deputy director at the Stevenson Cancer Center in Oklahoma City in the United States. Welcome to this educational activity entitled Harnessing the Power of Antibody-Drug Conjugates in Gynecologic Cancers. I'm very pleased to be joined by my colleague and friend, Dr. Susanna Banerjee. Would you please introduce yourself?
Thank you. Thank you, Dr. Moore. I'm Professor Susanna Banerjee. I'm a medical oncologist. I work at the Royal Marsden Hospital in the NHS in London, and I'm Professor of Women's Cancers at the Institute of Cancer Research. I'm really glad to be here today, and I'm really looking forward to our discussions in this really exciting area, in an era where we're developing new treatments in gynecological cancers. And we're going to cover some of those advances for our patients, and really looking forward to the discussions, sharing our perspectives for how we actually utilize drugs in the clinic.
Great. I'm excited as well. We have a lot to cover in 30 minutes, so let's get started. Our goals for today are three goals. The first is to really outline the antibody-drug conjugate or ADC regimens that have demonstrated thus far efficacy outcomes in ovarian, cervical, and endometrial cancer. We're then going to move on to antibody-drug conjugates with different targets and payloads that are under current investigation in clinical trials across gynecologic cancers. And then we'll end talking about some of the patient experience aspects, safety, adverse events, how to mitigate these, and how this plays into which of these agents might you select in the future for your patient with a gynecologic cancer. When we talk about antibody-drug conjugates in gynecologic cancers, there's a number of considerations. We're going to talk about, Dr. Banerjee in a minute is going to talk about the three that are currently available, but we anticipate there is going to be more, and we're going to be sort of faced with kind of an embarrassment of riches, potentially, of having multiple of these agents available to our patients. And the idea of shared decision-making is really going to come into focus as we discuss with patients which one, at which time, at which dose, and for how long we're going to use these medications, how we explain the risks in a way that they feel fully informed, explaining how they work in a way that explains why we think they may be an optimal agent for that patient. And specifically, when we're talking about clinical trials, why a patient might be interested, or why a clinical trial might be best suited for that patient. And then when we think about communicating with our colleagues, it's kind of constant updating on what antibody-drug conjugates are available and where globally. You heard Dr. Banerjee's in UK. We have colleagues and patients all over the globe with different access, to these antibody-drug conjugates. Some of them require testing, some of them don't. And so how the testing is done and what it means will be important in an increasing way globally. Coming back to prevention of adverse events, both acutely and cumulatively, is going to be a very important consideration for these active medications, as they move into settings, such as maintenance, for example. So we have a lot to learn. We're at the tip of the iceberg for antibody-drug conjugates in GYN cancers. And I think it's going to be an exciting time figuring out how to best use these for our patients. These are very elegant molecules. At their simplest, we kind of explain them like a Trojan horse. It's an antibody that targets a tumor-associated antigen, a protein that's on the cell surface. It binds, it gets internalized, and then via these linkers, there are payloads of very, very potent chemotherapy that get released by the acidic microenvironment of two-step lysosomal degradation. That's kind of how they work. We're basically delivering chemo. It's still chemo. We're just delivering chemo, hopefully, directly to the cancer cell with some bystander effect. So we can use much more potent medications than we can use systemically to the benefit of apparently much higher efficacy than we see with standard chemotherapies. That explanation is like overly simplistic as to how these antibody drug conjugates really work and how they differentiate from one another is chemically very complex. We have plenty of payloads and multiple antibody drug conjugates approved and more under development. And you're going to hear about these in a moment. This is just a slide summarizing the three that currently have, I think I can say global approval, but it varies globally. Tisotumab vedotin was the first antibody drug conjugate approved in gynecologic cancers for second line and beyond cervical cancer. And this has global approval. Mirvetuximab soravtansine was the first ADC approved in ovarian cancer, targeting folate receptor alpha. Also has global approval that continues to evolve as more countries approve this and then hopefully make it accessible. And then our most recent, of course, is trastuzumab deruxtecan based on Destiny-Pan-Tumor tissue agnostic approval for HER2 3+ gynecologic cancers. This is mainly a U.S. opportunity, although I think as Dr. Banerjee may point out, there are opportunities in some countries, ex-U.S., where it's approved. Whether or not it's reimbursed and accessible, I think, is a different sort of question. But I think we will see this gain traction in other parts of the world. And then at the bottom of this slide, you can see the other transmembrane glycoproteins or tumor-associated antigens, as I've caused them, that are highly expressed in gynecologic cancers. Some of them have prognostic significance, some don't. So it's an exciting time. So I'm going to turn it over at this point to Dr. Banerjee to maybe, can you take us through a recap of the data behind those three approvals that I just sort of zipped through really quickly, and then we'll go into investigational antibody drug conjugates.
Thank you, Dr. Moore. It's a real pleasure to go through the real top-line results that led to the approvals that you summarized. So we're going to start with the first ADC, as Dr. Moore pointed out, to gain approval, which was an ADC called tisotumab vedotin, which targets the tissue factor, and this was in cervical cancer. We know too well that this is disease in recurrent metastatic cervical cancer is a disease where we clearly need to make vast improvements, and this really was a step in the right direction, and hence the approvals. So tissue factor is a transmembrane receptor. It's highly expressed in cervical cancer. And the key parts here is that the actual payload or the chemotherapy aspect is MMAE, and that works on the microtubules. So this was the practice-changing phase 3 study in OVA-TV 301. I was really pleased to be part of the team recruiting to this study. And what we see is an improvement in overall survival. So with a hazard ratio of 0.7, that translates into a median overall survival from 9.5 months, far too low, as we know when we see patients in clinic, to 11.5 months. And there was also a progression-free survival advantage with a hazard ratio of 0.67, so a 33% improvement in progression-free survival. So based on the efficacy, in terms of progression-free survival and overall survival, this led to the approval and use of tisotumab vedotin in cervical cancer. So now I'm going to move on to ovarian cancer. And the target here is the folate receptor. And you'll hear a lot more about this during today's presentation and discussions, but also going forward in terms of in clinical trials. Now, the folate receptor membrane protein, now this binds to folate, which is highly expressed on ovarian cancer cells, the receptor. And importantly, what we know in ovarian cancer, this is mainly high-grade serous ovarian cancer, although we're learning about other forms of ovarian cancer as well. So this antibody portion of mirvetuximab binds to folate receptor, as we said, on the surface of the cells. And the actual payload here is DM4. And again, this works in terms of microtubule disruption. So here is the Mirasol study that was led by Dr. Moore. And again, I was really pleased to be working with her and colleagues on this practice-changing study. This is platinum-resistant ovarian cancer, where we know treatment options are limited and survival is, again, far too short. So what we see here is a statistically significant improvement in progression-free survival with a hazard ratio of 0.65, so a 35% improvement in progression-free survival. And you can see quite nicely the separation of the curves with standard of care chemotherapy versus mirvetuximab in platinum-resistant disease. But what was really compelling was the overall survival advantage here with the hazard ratio of 0.67, a 33% improvement in overall survival. So going from 12.75 months median to over 16 months. So finally, the next target, and this is actually across the gynecological cancers, is targeting HER2. And we're familiar with this in other cancers like breast cancer, but this has really now come to the forefront in gynecological cancers. And this is with trastuzumab deruxtecan or T-DXd. And what's different about this ADC is that the payload compared to tisotumab vedotin and mirvetuximab is that this is a topoisomerase 1 inhibitor. And we'll talk about this, Dr. Moore and ourselves, with regards to the significance of that going forward. Also, I'd like to mention when we're talking about the payload, it's important to think about the drug-antibody ratio, and this is 8 in the context of T-DXd, and as Dr. Moore's mentioned, is also potential bystander effects. So the practice-changing study was actually an early phase study called Destiny Pan-Tumor 02, and this was across tumors, as you can see. But what we're going to highlight is the endometrial, cervical, and ovarian cancer patient cohorts. So this is where patients had HER2 expression, so either 3+ or 2+. Local testing or also central testing could be used, and prior HER2 targeted treatment was also allowed. And this was in the second-line setting and beyond. And the primary endpoint was response rate, and it was confirmed response rate by investigator. So just to highlight that around 75% of patients enrolled had local HER2 testing. I'm going to focus now on the gynecological cancer cohorts, and what you see here is the response rates. And this is the update which was presented at the ESMO Congress recently. But what this shows is the response rate is what we reported previously. And in all comers, the response rate was 37%. In IHC 3+, it was higher than IHC 2+. But let's look in a bit more detail across these different tumor types: endometrial cancer, cervical cancer, and ovarian cancer. The main message here, if you look at the actual response rates, this is much higher than what we're used to with standard of care chemotherapy in this setting. And I appreciate the small numbers in individual tumor types and then breaking it down further into the actual level of expression across the tumor types. But nevertheless, certainly a very positive signal. And based on this, this was led to the FDA approval in HER2 3+ tumor agnostic indication, which includes the 3 gynecological cancers that we've just discussed. So in addition to response rate, we heard at the ESMO Congress the update on progression-free survival and also overall survival. And what was really striking was that whether by central testing or by local testing, it's quite clear that ADC, trastuzumab deruxtecan, targeting HER2 overexpressing cancers is making a difference. So in terms of, for example, if we look at the IHC 3+ central testing for endometrial cancer, we see the progression-free survival of over 20 months, 28 months, and overall survival reaching almost 3 years. So this is not what we'd seen in standard of care practice. We've also seen improvements in cervical cancer. We've already discussed how difficult this disease is to treat, and also ovarian cancer. So you can look at this in more detail during the presentation. What I really want to, build upon, following what you've seen in terms of the approved treatments is really where we're going next in terms of some of the clinical trials. So if we talk about the HER2 targeted agents, if we initially focus on T-DXd, you can see the Destiny program here. It's not only in ovarian cancer, but also endometrial cancer, for example. So if we look at Destiny Ovarian 01, this is T-DXd with bevacizumab versus bevacizumab in the first-line setting as maintenance therapy. So what we've talked about before in terms of approvals, this is about treatment. But now, as Dr. Moore highlighted earlier, bringing the concept of these drugs in different settings and earlier on, and this is in the maintenance setting, a randomized phase 3 study. And moving on to endometrial cancer, there's T-DXd, but actually in combination with targeting the immune pathways. This is a bispecific TIGIT and PD-1 inhibitor, rilvegostomig, or pembrolizumab as first-line therapy in HER2-expressing MMR proficient endometrial cancer. And then going even further forward in the patient pathway, the Destiny Endometrial 02, this is a phase 3 study of T-DXd versus standard of care chemotherapy with or without radiotherapy as adjuvant treatment for HER2 expressing, that's 3+ or 2+ endometrial cancer. So it's giving you a flavor of where the aims are of moving ADCs forward, and these trials will help elucidate whether there is a role for that and in what setting and which patient cohorts. And I want to expand upon folate receptor. Of course, mirvetuximab has really been at the forefront changing practice. And there are other FR-directed ADCs. And I think one of the questions is whether we can expand the population of patients that may benefit from FR-targeting ADCs. So not only to that FR-high level, but beyond. And some of these new drugs under investigation are of interest. And one of those is Rina-S. Rina, how about Sestucan? I think these names have to get better. So Rina-S. So this is an early phase clinical trial, Rainfall 01. And I want to point out again, something this is important when we discuss things about the payload. And this is a topoisomerase inhibitor payload, so different payload to mirvetuximab. And that may well be relevant when we're talking, about sequencing at some point. So this is an early phase study. And the response rate in ovarian cancer in this study was, as you can see, promising in sort of over 50% at 120 milligrams per meter squared. And in endometrial cancer, again, above 40%, 50%. Let's continue. There's more targeting folate receptor, and there's AZD5335, which has now got the name Torvuta-S. And this is again, early phase clinical trials called the Fontana trial, which is really looking at the dose, either, in terms of escalation, expansion, and also combinations with this FR-targeted ADC. And at ESMO this year, we saw the results of the platinum-resistant ovarian cancer cohort, and you can see the waterfall plot here. And of note, after around 8 months follow-up, over 50% remained progression-free, and the response rate was over 50%. So encouraging, and we need to see further studies expanding, looking at combinations and looking at folate receptor levels in more detail. So I'm going to move on to another target, and we don't have an approved drug in this setting in terms of targeting cadherin-6. And this is a really exciting target and drugs being developed in this area. Raludotatug, deruxtecan, or R-DXd. And this is an ADC, again, targeting topoisomerase 1. So here are some of the results from phase 1 trials in platinum-resistant ovarian cancer and also platinum-sensitive ovarian cancer. And many of the traditional ways we've developed trials have been in platinum-resistant ovarian cancer and then moving it along the patient pathway, thinking of platinum sensitivity maintenance and different lines of therapy. What I think is really interesting and exciting, although early phase clinical trials, is seeing activity in platinum-sensitive ovarian cancer. The way we're treating patients and therefore the effect of prior treatments is influencing the response to subsequent therapies. And if we can reserve platinum for a later date or help with the sequencing with other agents like ADCs, I think that's a really interesting concept. So in platinum-resistant ovarian cancer here, response rates of almost 50%, and in platinum-sensitive ovarian cancer, small numbers, but over 70%. And those waterfall plots are very exciting to see, and we need further trials in this area. So that leads me on to the Rejoice Ovarian 01 study. And this is a phase 2/3 design. So studies are moving very quickly, trying to look at efficacy signals so that we can then expand into larger randomized studies so we can hopefully get these drugs into patients if they're hopefully efficacious and safe. So this was the phase 2 dose optimization prior to the phase 3, and this was presented at ESMO this year as well. So these are the main headlines. This is to remind you, this is monotherapy in platinum-resistant ovarian cancer, various doses, as you can see here. But the main message here is looking at that waterfall plot, where the majority of patients have evidence of some shrinkage and response rates of ranging from 44% up to 57%. And importantly, meaningful disease control rate signals as well at this stage. So encouraging to go into the phase 3. So with the phase 3, the 5.6 milligrams per kilogram dose will be going forward. And not only Rejoice Ovarian 1 and the platinum-resistant ovarian cancer setting, there are other studies ongoing too. There's the phase 1/2 Rejoice Ovarian 02 study, and that's actually looking at combinations. So we've talked about monotherapy, and now it's about combinations with other agents, including chemotherapy. So in this study, it's looking at carboplatin or paclitaxel in platinum-sensitive ovarian cancer, or indeed combining with bevacizumab in platinum-resistant ovarian cancer. And beyond high-grade serous ovarian cancer, the phase 2 Rejoice Pan-Tumor 01 study is looking across multiple tumor types and of relevance to gynecological cancers. There's endometrial cancer, cervical cancer, and non-high-grade serous ovarian cancer. And I'm very excited about potential activity in these other cancers and other subtypes of ovarian cancer. So the FDA granted breakthrough therapy designation to R-DXd in September 2025, highlighting the potential for this drug, and I'm very excited to hear more over the next few years. So, but beyond folate receptor, HER2, and cadherin-6 that I've talked about, Dr. Moore introduced earlier, there are many other targets, and there's been a lot of interest in targeting TROP2 across different tumor types beyond gynecological cancer and also gynecological cancers. So I'm very excited to hear from Dr. Moore about the latest with TROP2 ADC clinical trials.
Thanks so much. Thanks for that great overview thus far. So I'm going to talk about the ones that have probably the most mature data, and those include sacituzumab govitecan, datopotamab deruxtecan, or Dato-DXd, and sacituzumab trmetecan, or SAC-TMT. As I mentioned early on, just because there are these 3, or in fact 17, TROP2 targeting antibody-drug conjugates with camptothecin or topoisomerase inhibitor payloads does not mean that these are kind of, interchangeable. I mean, they are very different agents from one another. Of course, sacituzumab govitecan has an SN3 payload. The linker, we don't have time to go into the chemistry, but the linker technology of SG is very different than the linker technology for Dato-DXd or SAC-TMT, and it leads to different kind of biologic activity and pharmacokinetics that may be more or less beneficial in certain tumors. These are very different molecules. These are the three that are farthest along under development for GYN cancers. And so I'll just show you the data that exists today, which is relatively small numbers. For sacituzumab govitecan, this is actually the antibody drug conjugate we had some of our first readouts on, just in general, and then certainly for TROP2s, really based on the work of Alessandro Santine from Yale, who's been championing this as a target for probably a decade or more. But he's done some investigator-initiated trials and then also led the TROPiCS-03 study, which had an endometrial cancer cohort. This was a second line and beyond study, so post-paclitaxel carboplatin, an area a very high unmet need where monotherapy chemotherapy has a 15% response rate and a expected median PFS of 3.4 months. That's what you get with doxorubicin or weekly paclitaxel. So this came in an unselected population of patients with recurrent uterine cancer, heavily pretreated. Almost all had prior immunotherapy, which is an important kind of thing to say, and had a response rate that was modest, 22%, and a median duration of response of 8.8 months, which is actually pretty good. But if you looked at the waterfall plot that you can see here, over 60% of patients experience some shrinkage of their tumor, which clinically is what we care about. And then you can see the progression-free survival and the median on the right-hand side of this slide. When you look at this is the phase 2 study I referenced. This is the investigator initiated clinical trial that was also led by Dr. Santine. Here he selected for TROP2 kind of high, his definition of high. And so you had a response rate that went up to 26%. So there did seem to be a little bit of difference, but not much, which is kind of what we think about TROP2 as a biomarker. It just hasn't quite hit yet on whether or not it matters. You can see the median PFS and OS in a selected population. But this did look reasonable enough and better than monotherapy chemotherapy to move it into a registration-enabling phase 3 study, which is the ASCENT-GYN-01, which is in patients with recurrent uterine cancer. They have to have seen paclitaxel and carboplatin, and they have to have received an immunotherapy, either with paclitaxel carboplatin or as a part of like lenvatinib pembrolizumab or monotherapy immunotherapy as second line. But they have to have received IO up to 3 prior lines, over 600 patients, and dual primary endpoints of progression-free and overall survival. This has been open and accruing for a bit. It's getting close to the end, and so we'll be looking forward to seeing this readout in the near future. For Dato-DXd, we saw data at ESMO in 2024 regarding efficacy in a similar population, single-arm study, post-paclitaxel and carboplatin. Not all had received prior immunotherapy because this was done mostly ex-US where it's not as available. And they were looking at 6 mg per kg of Dato-DXd every 3 weeks. So this is a different schedule for TROP2s. The others are all some version of weekly. And what you can see here, this is endometrial and ovarian cancer. And ovarian cancer was platinum resistant, response rate of 27.5%, and then 43% in the ovarian cohort. So again, signals of efficacy here with reasonable durations of responses that you can see listed on the slide across recurrent tumor types that lend more support for activity of this TROP2 targeting deruxtecan payload in recurrent gynecologic cancers. And then SAC-TMT, we saw some updated data at this ESMO. This was done in China, but you can see on the left-hand side of this slide, the endometrial cohort with confirmed response rate. If you look at both dose levels, that they were optimizing of 32%, which is a nice signal. And then in cervical cancer on the right-hand side, you see a confirmed overall response rate of 24%. So could this be another option in addition to tisotumab vedotin, which is a different target and a different payload, to really optimize outcomes for patients with cervical cancer, I think remains to be seen. And there is an ongoing phase 3 study in both of these settings, endometrial and cervical cancer, with this agent. And so we'll see how those play out. And then we have that there's not enough time to tell you about all the other things, but we have B7H4 entering phase 3 studies with puxitotug samrotecan. This is in the Blue Star clinical trials, phase 3 study in recurrent endometrial cancer, and there's even more. So, and you can see the disease sites that they are studying. It's kind of across the board. And so we're going to end with just a little bit of discussion on perhaps one of the most important things, which is safety. And so I'm going to pass it back to Dr. Banerjee to take us through sort of how all these look like they're working. So safety really becomes the decider in some situations of kind of what you're going to use. So turn it over to you.
I'm going to start with adverse events, side effects, toxicities that we are not used to in gynecological cancers. And the reason I'm going to do that is so we can highlight those and actually show that they are manageable. And like when we have new treatments like immunotherapy, we learn and adapt and know how to best support our patients from a safety perspective. And so ocular eye toxicities are something that we have noted with ADCs, not all ADCs, but perhaps to some extent, we are also looking for it more and also noting it. So what's really clear when counseling patients is avoiding wearing contact lenses and also being aware of reporting changes in vision, eye side effects. And the key thing is being linked in with an eye specialist, ophthalmologist, for example, in order to note these events so that we can act quickly upon them before they can become more problematic. The other important toxicity with ADCs, I would argue across the board, and I'm going to illustrate this with T-DXd, is interstitial lung disease, so pneumonitis. So this is probably one of the most important slides, looking at detecting and managing interstitial lung disease. And there's the 5S rule: screening, so look for this, monitor, scanning, in terms of CT scans, baseline scans, high-resolution CT scans, multidisciplinary management, education of patients, teamwork involving respiratory or pulmonologists, and also knowing when to hold treatment. So it's really important not to continue if you are seeing significant changes on imaging and also symptoms. So T-DXd, for example, should always be interrupted if this is suspected and can only be restarted if this is asymptomatic. And steroids is key here. Swift action in terms of starting steroids and monitoring patients very carefully. So now I'm going to hand over to Dr. Moore about other side effects and how we manage these.
But it's how we keep people safe, is this multidisciplinary care. So we need our pulmonologist colleagues very much to be involved in the care of our patients. But it's not the only thing. It is certainly the thing that we talk about the most, but it's not the only thing. We are seeing other toxicities, some of which we're used to managing. So neutropenia, we are used to managing this as oncologists. We're pretty good at that. There is becoming more of a need to use sort of prophylactic G-CSF kind of right out of the gates, sometimes based on fragility factors or baseline creatinine clearance. So there's also an evolving set of criteria that maybe we don't kind of wait and see. And if we need it, we add it cycle 2, like we do with many things. Here, kind of right out of the gates, we're going to be using G-CSF with some of these agents and getting comfortable with that. And then diarrhea, mirvetuximab, 30% of patients have diarrhea. It tends to be low grade, and we can manage it very effectively with, in the US, what are over-the-counter agents, and other parts of the world have to be prescribed. But it doesn't tend to be something that people are housebound because of the diarrhea. But with sasigovitecan, which is potentially going to enter the GYN treatment realm if we see any of these phase 3s read out, none of us have used this medication. They're very familiar to our breast cancer colleagues. They know how to mitigate the diarrhea, assess for the UGAT1 polymorphism, dose reduce as a result of it. We've never used this. And so really making sure that our community is trained on the more severe diarrhea risk. The other one is mucositis. And again, it's not like we've never seen this. If we've used mTOR inhibitors, which we do, we've seen mucositis. We've seen it sometimes with pegylated liposomal doxorubicin, but not that much, and not to the degree that we're seeing it with some of these TROP2 antibody-drug conjugates. Now, this isn't something we see with Sasi-Gobi. This is something we've seen with almost every other TROP2 ADC. If you look at Lightfoot et al., it just came out specifically in the GYN community to train us on how to prevent and then mitigate, if it happens, the mucositis that can come with some of these agents. It's very exciting to be in GYN oncology right now because we have so many more active medications than we've ever had. And it's, in my view, there's patients that I'm taking care of that, quite frankly, would not be alive today if they hadn't been put on an antibody-drug conjugate. And I don't know what you think, Susie, while we get these studies done, figure out which one of them will get approved, and then really do the hard work of figuring out which one for which patient and what dose and how long to individualize moving forward.
I'd agree with that. And I think in the meantime, as we're running these trials, it's really important that patients are referred to have access to these trials so we can work this out, but also to get familiar in practice with the 3 ADCs that we have approved already. So we're very used to this, used to looking at pneumonitis, used to looking at ocular toxicities, so that when more ADCs come in, we don't have that hurdle to try and understand as well in terms of managing toxicities. So I think it is an exciting time for our patients, knowing that, as you really nicely put it, having an opportunity to survive another milestone, and that's what we're here for.
Right. Exactly. It's exciting.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by independent educational grants from AstraZeneca, Daiichi Sankyo Incorporated, and Gilead Sciences Incorporated. To access all materials for this activity, visit peerview.com/UAD860.